I was asked to speak on putting in a non-motor perspective to the whole issue about Parkinson's. You've heard from that wonderful introduction by Eric Walters about the various issues about non-motor problems all throughout Parkinson's, really, and again from Alex Iranzo's talk about its overwhelming importance in the early stage of Parkinson's. So a lot of the work that I'll present is based on our groups and our collaborations with various people, some of them much been in the audience at King's in London. So first I want to just quickly touch upon non-motor symptoms of Parkinson's and what is generally known, perhaps in the last 10 years or so. First thing is the extent of neurodegeneration in Parkinson's. What we often don't take into account is that in many patients with Parkinson's, non-dopaminergic cells might actually degenerate to a greater extent than the dopaminergic cells. This would obviously have an impact on the clinical phenotype of the patient. So for instance, this particular work from De Kock et al. Showing that you can have up to 90% cholinergic cell loss. You can lose your orexin cells in 60% or so. Serotonergic cells can be lost in up to 40%. Noradrenergic cells can be lost. So depending on the selective vulnerability of these cells and cellular loss, we might see different expression. And as you would recognize, that the symptoms underpinned by these neuropeptides are related to non-motor symptoms. In fact, very elegantly shown in this very recent review by Horacio Kaufman and Alberto Espe and colleagues, that you could even consider Parkinson's a noradrenergic disorder, and this can underpin not just central abnormalities, but peripheral abnormalities. Heart scanning, for instance, can show up early stages in Parkinson's abnormalities. Here's a scan from one of our own labs, a patient with nice visualization of the heart on MIBG cardiac scanning, which binds with or marks the noradrenergic uptake in the heart. And here we have a patient with Parkinson's, very early stage, with absolutely no visualization of the heart. So it's not dopaminergic. We're now looking at noradrenergic phenomenon. The non-motor symptoms are also important from the clinical point of view. We mustn't forget the patient. And if you look at quality of life, and there are a whole range of papers here from our group and many others, showing that the overwhelming link of non-motor symptoms is the burden, the number of different non-motor symptoms, not just one, not just cognition, not just depression, not just anxiety, but the burden of it is a key determinant of quality of life, not just in advanced Parkinson's, but also in early Parkinson's. On an average, your patient in front of you will present with 8 to 13 different non-motor symptoms, and that is a challenge in clinical practice, and that is why perhaps many of us choose to ignore it. You've already heard about the pre-motor marking of non-motor symptoms with hyposmia, and I would say late onset hyposmia, not just any hyposmia. And late onset idiopathic hyposmia will probably be the right terminology, along with rapid eye movement behavior disorder would probably in future emerge as one of the most potent markers of this period. And in fact, a very nice study by Annette Schrag published in Lancet Neurology last year again highlights this. Here you have in blue motor control, and in red are the different non-motor symptoms, and each one marks a year before their motor diagnosis is made. So the motor diagnosis is made at this point, this point, this point, and this point. You can see that problems such as depression, anxiety, fatigue, and constipation in these patients were persisting for over 10 years before their motor diagnosis is made. And this again is it has been replicated, let's say, in a lot of papers in the last few years. So we can have a timeline of this, like this. You have approximately 20 years prodrome, some would say 30, some would say 5. And then you have the clinical onset of the patient, that's when we make the diagnosis. And then you have a 20-year journey with Parkinson's, going through the H&Y stages and its usual milestones. So you can therefore understand why none of the neuroprotective treatment works, because they come in too late. You have the condition, as you've already heard, for a fair few years before the tremor and the bradykinesia becomes evident. However, another new thing that we have now learned is that non-motor symptoms can be classified. They're not all the same. And you cannot just clump everything into non-motor symptoms. They could be dopaminergic, they could be non-dopaminergic, they could be fluctuating depending on non-motor fluctuations, they could be related to drugs, and finally, now we're understanding certain genetic patterns of Parkinson's, particularly LRRK2 mutations or glucocerebrosidase mutations, carry some specific patterns of non-motor symptoms. Sleep problem in LRRK2, cognition, depression, anxiety in GBA mutations. So you can see again a complex pattern, and we need to try and identify the pattern of non-motor symptoms that we're trying to treat. Another area of non-motor symptoms that we have now learned is that we can empower patients. We can tell our patients to tell us about the non-motor symptoms. This is done through the non-motor questionnaire, which we developed in 2006. It's now used around the world, and there are about 8 international studies. Over 2,500 patients have been studied with the NMS Quest, and this would suggest that, again, on average, a patient will have 8 different non-motor symptoms, and this has been studied in various groups around the world, not just our group. We also know that in spite of our best efforts, we do not ask the patients about non-motor symptoms as much as we should, or patients don't tell us, and this leads to rather devastating consequences. Here we have a study from several centers in Europe, and we see, for instance, depression and anxiety was not declared in about 39% of patients, sleep disorders not about 45% of patients, gastrointestinal problems not declared in about 43% of patients. Why? Because either the doctor doesn't have enough time or the patient doesn't associate the symptoms with Parkinson's. But overall, this has a negative effect on care, because all of these symptoms can, of course, be treated, or at least attempts of treatment could be made. Other area that we have developed is the measurement. And this is a very nice editorial by Tony Shapira last year, showing not just the motor, but the non-motor symptoms can be measured. And it's amazing that we have clinical trials of new drugs which don't make any attempts to measure non-motor symptoms. And the importance of this is this recent paper from our group with our international collaboration shows that you can do cutoffs. So if you simply get a patient to mark the non-motor questionnaire, depending on the number of NMS they have, you can stratify the patients to mild, moderate, severe. You can then combine that with an H&Y stage to get a holistic measure of the patient, which really reflects the patient as it is, not just motor measures. And in fact, there are 3 ways of doing it. You can either do it with the non-motor scale, for which valid grading has now been published. You can do it with the questionnaire, which I just showed you, or you can do it with the MDS-UPDRS Part 1, although that lacks not all the questions related to non-motor symptoms. And of course, the great advantage of the NMS Quest is that this is patient-completed. So that's another thing that we have in our armamentarium now, and this is something that we certainly do in our clinics routinely. What is new is the next bit. Well, the first thing is neuropathology and the changing concept that Parkinson's is not a static condition in terms of neuropathology. It's not something where you have a Niagara burden or a brainstem burden and that's it, but it progresses. We know that. But interestingly, the roots of progression have been a source of major interest in the last few years. This work or proposal from Kurt Ellinger and subsequently by several others, including Glenda Halliday and Chuck Adler's group, would suggest that one entry route to Parkinson's is likely to be through the olfactory bulb. Not surprising, because we have a fairly consistent hyposmic problem in Parkinson's. And these patients then have two routes. One should go through the brainstem area, another through the limbic area. So brainstem. So already you can see endophenotypes. The brainstem predominant phenotype, limbic predominant phenotype, which might merge in some to become a brainstem and a limbic phenotype. Now, the importance of this is that they will have different type of symptoms and largely non-motor symptoms. So in fact, while the brainstem predominant phenotype or endophenotype would express symptoms such as RBD, excessive daytime sleepiness, and dysautonomia, the limbic predominant syndrome would have more limbic syndromes in the form of apathy, which we now know is a dominant non-motor problem in PD, fatigue, cognitive issues, and perhaps pain as well. The central opiate generator of pain is largely driven through the limbic mechanism, for instance. So this has led to a fair amount of work looking at clustering and subtypes within Parkinson's. Our traditional view of subtyping within Parkinson's is motor, tremor dominant, akinesia dominant, PIGD, or a mixed pattern. But we know after 5 or 6 years, these patterns largely merge. This very nice piece of work from Paolo Barone's group by Roberto Aero and colleagues would suggest that if you looked at Parkinson patients at diagnosis, so these are untreated Parkinson's, which is really the model to look at, because otherwise you're going to find treatment-related non-motor problems, and you did a latent cluster analysis, you would find 4 groups. And these they've termed pure motor, pure non-motor, or non-motor dominant, a motor dominant, as well as a mixed motor and non-motor. And there are some specific symptoms that stand out, urinary problems, perhaps autonomic in the non-motor dominant cluster. Another very nice study has just been published called the Onset PD study, and this is again a collaborative effort between the Austria group and the group in Barcelona with Alex Iranzo and Eduardo Tolosa. Very nice study because they looked at 2 independent cohorts of patients, specifically focusing on non-motor symptoms by a questionnaire and in untreated PD patients and controls. One thing emerges that 17 of 31 different non-motor symptoms were common in patients, sort of echoing our original idea. But once again, if you look at the clusters, 4 clusters emerge. And they have a cluster of REM behavior disorder with constipation, dorsal nucleus of the vagus, and the pedunculopontine fairly closely situated in the brainstem. We have the mood cluster, we have a cognition cluster, and we have a sensory and dysautonomia cluster. This would also fit in very nicely with our limbic and brainstem paradigm. The same clusters can be seen also in the other group, in the Innsbruck group as well. Now, this can be taken further, and it's not actually that new, because our chairman with Heiko Brack described very elegantly how the Niagara brainstem pathology can coexist with a whole medley of non-motor symptoms, which are listed on the left there, going from hyposmia to swallowing to constipation to cognitive and executive dysfunction. But we've sort of tried to take this further a little bit and have this described in the supplement here, and there's a paper coming out in Movement Disorders about the first description of specific non-motor subtypes within Parkinson's disease. And we think there are 7 of them. And these vary from what we've termed park cognitive to park apathy, depression, anxiety, sleep, pain, fatigue, and autonomic. Doesn't mean that they won't have the other symptoms. Of course they will. But this is the dominant expression, just like you would do in MS, for instance, just like you would do in motor neuron disease when you look at the different subtypes or subgrouping within them. And this is largely based on 3 different routes of spread. The first route is the Brack's route through the brainstem, and that's the bottom-up hypothesis. These patients will often have late-onset hyposmia as well, and largely in terms of the clinical profile, they'll have a sleep dysfunction or dysautonomia as their main profile. The second one, which not many people talk about, is the beach hypothesis from Chuck Adland from the Mayo Group, suggesting an olfactory spread into the limbic area. And these patients are often anosmic rather than hyposmic. And they have mainly depression, fatigue, sometimes central pain or weight loss. And the third type, which is the Glenda Halliday's proposal, the so-called neocortical subtype, is based on later onset, and contrary to the Braque theory, in these patients, cognitive issues dominant, and these are largely amnestic, mild cognitive impairment, apathy, perhaps mixed with anxiety, interestingly, also often with on-period related or on-freezing and falls. If we go into this a little bit further, you might think I'm making all this up. Where is the evidence for this? Well, there is evidence in terms, let's look at the GI variant, for instance. A very nice piece of work recently published, in fact, only a few weeks back, by Lisa, who worked with us, and Heinz Reichmann, puts up this very provocative and very interesting hypothesis of the gut-brain axis. And this is one of the subtypes, the GI subtype. And this really relates to the vagal nerve, which, as you will see, is very closely related to the dorsal motor nucleus of the vagus and the gut. And there is quite an interesting work, this is work published this year from Sweden, suggesting that if you put in a toxic alpha-synuclein lysate into the intestine there by injection, it shows vagal spread to the DMV and subsequently to the Niagara, suggesting that the olfactory route or the brainstem route might even have a gut-related origin through the vagus. And in fact, this is again taken from Heinz Reichmann's lab work. If you look at animal models, here is a control animal. Here is an animal that's been made Parkinsonian with rotenone, and you can see that here there is increased alpha-synuclein deposition into the nigral area, and then you've cut the vagus, and if you cut the vagus, the vagotomized side shows little accumulation of alpha-synuclein deposition. And in fact, there's a very nice paper in Annals of Neurology just out a few months back suggesting that if you looked at, and this is a retrospective piece of work from Denmark, that when they looked at their cohort of patients who underwent truncal vagotomy versus selective vagotomy, the risk of Parkinson's was significantly lower in those who underwent truncal vagotomy. So provocative ideas, but there is proof accumulating about the gut and the gut phenotype of Parkinson's. And I'll also move on into surrogate markers to end the talk. So we have, for instance, if you remember that Paolo Barone's cluster analysis showed urinary dysfunction as a specific problem within the non-motor dominant group. And this work from Roberto Ero's group again suggests that if you have a Parkinson patient who at the onset of it has autonomic problems, in other words, has the brainstem phenotype, they're likely to do worse. If you follow them up, they will have greater levodopa requirement and they will express some other signs of Parkinson's. So already we can see the natural history of this condition is changing or might change based on the initial presentation of non-motor symptoms. We also have similar points emerging with other phenotypes. In the RBD phenotype, which you heard from Alex's great talk, but with RBD, if you then have mild cognitive impairment in combination and orthostatic hypotension, they might coexist. It is likely that these patients will have a malignant or a very aggressive spread of the condition versus who don't. So that's, again, the subtype and the correlates marking the progression of that condition. And staying on with that, fatigue is also another area. Fatigue is an independent symptom of Parkinson's. And this work, which we did with David Brooks a few years back, we looked at dopaminergic and serotonergic pathways within the brain. And interestingly, what you find that here you have a healthy volunteer, here you have a patient without any fatigue, so non-PARC fatigue patient, and here you have the PARC fatigue phenotype. So in the PARC fatigue phenotype, what you see, with eyeballing, complete washout of central serotonergic limbic binding. So it doesn't happen in everybody. We're saying that this is in the specific limbic variant of Parkinson's. Clinical implication of this is that if we are to treat fatigue in Parkinson's in future, maybe we should be looking at serotonergic agents. And a trial of that has recently started. And if we look at the various different new clinical trials for non-motor manifestations of Parkinson's, very recent review that we published in Movement Disorders, it's nice for somebody like me who's more interested in this area to see that now we are having emerging trials in psychosis addressing serotonin pathways, depression, dopaminergic and MAO pathways, sleep, GABA, melatonin pathways, postural hypotension, adrenergic pathways, pain, opiate pathways, and even impulse control disorder, a very recent naltrexone trial that's been published using the opiate pathways. And in clinical practice, this is very interesting. This is a very recent paper in Lancet Neurology, which reports the first ever randomized placebo-controlled study of an opiate drug for PARC pain phenotype. This will not work in everybody. This will work in those who are expressing high pain scores, and that's not all Parkinson patients. So enriching that cohort is critically important in our future trials. So what about new dopaminergic drugs? I'll come with some bad news for me, might not be bad news to you. The bad news is that, as far as I can see, these new drugs, safinamide, the new apomorphine buccal formulation, the accordion pill for levodopa, the levodopa skin patch, neuroderm, the inhalation, the Civitas, as well as opicapone, again have just focused on an increase of motor off period of 1 hour, of 1.5 hours, and so on. And none of them have any trials, as far as I can say, in terms of non-motor symptoms, which by default remains one of the main determinants of quality of life. However, the good news is that all things still often carry most weight. Our older drugs, levodopa infusion, for instance, apomorphine infusion, rotigotine transdermal patch, and DBS have all, or will all have, in the next 2 or 3 years, very, very strong emerging non-motor data, because they are focusing on that. And that is, I think, the right way to go. Because a Parkinson patient treatment in future, patients are also going to want to have treatment for their non-motor symptoms because they are aware of the issues. And in fact, if you look at the MDS clinical diagnostic criteria, and Professor Walters touched upon it, I'm very happy to see that also the new criteria have both addressed non-motor symptoms. This is the clinical diagnostic criteria by Ron Postuma, and the research criteria, which is a very interesting piece of work by Daniela Berg and colleagues, which has tried to look at motor and non-motor clinical symptoms and give a ratio, because this can help enrich clinical trials in future. And in fact, if you look at the prodromal markers, and this is their likelihood ratio, the highest ratio, almost 130 here, is driven by polysomnographic proven REM behavior disorder. So RBD, as Alex just said, with PSG proven RBD, is probably going to be the key marker when we try to attack that first and early phase of Parkinson's disease. This also takes us to another paradigm which we have proposed recently in clinical practice. So we can have non-motor symptoms either isolated, so you can have a patient who has severe hyposmia or severe RBD, for instance, or you can have what is more likely a combination of different non-motor symptoms. And in this situation, application of the MDS prodromal, the Berg criteria, might be very useful. With this, you'll have a group that will be positive for prodromal Parkinson's, a group that will be negative for prodromal PD. In the positive prodromal PD population, again, you'll have the dominant NMS subtypes, one of those 7, or in some, you'll have motor dominant subtypes, and in some, you will not be able to make out, so there'll be the mixed. But in the NMS dominant subtypes, This could be then used to have an enriched sample for clinical trials. An example would be, if you have a patient with PARC sleep, you're not going to do a dopamine agonist study on them, because if you give them a D3 agonist, they'll fall asleep in front of you. So you will exclude that group, for instance. So these are possible ways that we might be going in future. And of course, the natural history of the subtypes and how much of this negative prodromal PD might actually convert to the positive. These are questions we do not have an answer for, and I think we'll be looking for in the future. I'd like to end there, and I thank all the people who have been working with me. Thank you very much for your attention.